Oh, and you are, no, PNR204. This is week 7. And this week, we're going to be going over your child with a condition of blood or blood forming organs, lymphatic system. We're also going to go over to some GI conditions also. Discussion question 5 is due this week. And then your CJ Sims. I got to tell you, there was only 2 that didn't get it done. That now it's all done on they're 5% for each one. So I really get underneath and send you messages to be sure you get them because they can affect your grade. 5% when I turn on those grades do make a big difference. And I don't want that to be the difference that makes you not be successful in passing. That would make me feel horrible if I didn't remind you. So here we go with our blood and blood forming organs, lymphatic systems. So lymphatic system, what is it? It's a place where infections go to, and all the lymph systems, which is all of the white cell type things, go there and attack it and destroy these organisms. So when we have a problem with the lymph system and they're enlarged, what's going on? There's an infection of some sort. Is it, that sore throat, or is it something more? And we can look just by looking there. Now, we have this lymphs everywhere. We can see the ones in the neck. Those are the ones that we think of are underneath the arms, in the groins. The spleen is usually very small. You can't feel it, but it is the largest organ that fights all of these infections, okay? One of the things that the spleen does is to bring blood into contact with the lymphocytes so that it can make sure that it's carrying all of this good stuff to the body, fighting infections. When we see this organ, the spleen, and all the lymph nodes get elevated and swollen, we know that there's something's going on. So blood, what does it consist of? Well, there's a lot of liquid, then there's red blood cells, white blood cells, and then there is your stuff to clot. So blood takes care of a couple things. It's the volume in the blood, so dehydration can be measured by volume of blood. It's the red blood cells, carries oxygen and iron to the body, so it keeps us strong. And the leukocytes are white blood cells, which fight infection. And then the third thing is platelets. So we have to do with keeping us not anemic and strong and full of energy, fighting infection, and that we're not going to bleed. Those are the things that our blood system does for us. So, as I said, erythrocytes carry oxygen, iron to the body, and then it gets rid of the byproduct, carbon dioxide from the lungs, and gets rid of it. Again, the leukocytes fight infections, and part of that whole system is the lymphocytes, because that is produced in the lymph node tissues, in all of your glands, which help, again, infection. So let's take each component. So we have the blood, our iron, our strength, then our infection, and then bleeding. So here we go. So anemia, in children, we consider it below 8. And we not only consider that a hemoglobin below 8 is, are you becoming symptomatic? Now, some children with a hemoglobin of 8 are normal, active, playing right, not short of breath, and looking great. There will be another child that has a hemoglobin of 8, and that symptomatic is now the heart's trying to beat faster, trying to get that oxygen around to the body, and the heart's beating so much, you're even going to hear that swishing through the valves in the heart, and it's going to tire out. And when the heart tires out, can't pump this blood as well, you're going to see now the iron and the oxygen's not getting to the body, and you become pale, like you see with anemias. You're going to be weak. You don't have oxygen. You have no energy. You're going to be breathing faster, trying to get oxygen, but you don't have cells to carry it. And of course, short of breath, your heart's failing. You'll see that congestive heart failure. So iron deficiency, probably the most common. Now, when do we see iron deficient anemia? Well, usually we don't see it in the first 6 months of life. because you're born with mommy's blood. And it usually stays around till up around then. It starts happening as the baby's cells coming from mom die, and their body's not catching up to making enough cells yet. So you're not have enough red blood cells. That's one of the things that causes anemia. But also it gets into now diet. The first 6 months, what do we give them? We give them breast milk, or we give them iron fortified formula. And we also give, our vitamin D with breast milk because it helps with the anemia and preventing it. Now, as we start putting diet in there, especially when we go to that 12 months. So 12 months, they say you can start giving whole milk, right? It doesn't have iron in it. So it can lead to that anemia we're talking about. So, and in iron deficient anemia, as they get older, they're starting to eat more food, they're eating less milk. Moms usually decide around that time to stop breastfeeding, and then they stop feeding them formula. They're not getting all the extra iron fortified cereals. We're not doing that. We're giving more, table food. They're not getting what they need. So toddlers are probably at your highest risk, that right around 12 months to 24 months, because they only eat certain things, they're picky, and they eat, very little at this time. So with anemia, it doesn't matter, babies, adults, they're all the same. What do you see? You'll see this child, they're going to be pale, they're going to be irritable. Why irritable? No oxygen's going to the brain. So they don't know what's going on, right? They're not going to feel that great. So they'll show it being irritable. They have no energy, so they don't want to eat. So they're anorexic. They don't want to do anything. They sit in the corner and they sleep a lot, which is unlike your child at that time, right? And then sometimes you'll see that babies are getting more milk, which is no iron in it, and they're getting overweight because of the high fat, et cetera, in it. But they need that. But then they're overweight. They don't have enough iron. Now they can't carry the weight. Now they're getting tired because of the weight. So it was one of those, yes, it's good to feed them, but it's, what we feed them. So how do we look at this? Having a mother complaining they're tired, they look pale, and they're not active like they used to be. Number one, it's just a simple CBC, a red blood cell, a hemoglobin hematocrit, and looking at the cells, because there's not just iron deficient anemia, there's many of them. And most likely we're going to see those levels low with all of those symptoms. Now, what else could cause hemoglobin and hematocrit levels to be low? Just bleeding, right? So we need to rule out an obvious thing, which could be GI bleed, could be stomachs, could be intestines. So again, a stool for occult blood, let's rule out an obvious cause. I always say, let's treat not the symptom, but let's treat the cause of it. So if we know if it's bleeding, we could take care of it. So in iron deficient anemia, we need to give our children a diet high in iron. We know that a lot of these children don't want it, or it's low. We need to supplement it and do it now. Treatment is going to be giving them iron. There are certain things with iron you need to know. With iron, it's liquid. So usually it's through a straw, so it doesn't get on the teeth. It is always on an empty stomach before meals. And if it can, give it with orange juice. And why all of that? Well, iron is digested, made into a product that works for the body better because of the digestion of the stomach acid. So stomach acid breaks it down. Well, what is vitamin C? Orange juice. It's an acid. It breaks it down and makes the iron more readily available for the body, and that it gets to the cells where it needs to go, will help the child with energy and eating, et cetera, et cetera. So we know if the child's not getting enough of oxygen and iron to the body, which is carried through red blood cells, they're not getting nutrition? What are some things that happen? It really doesn't matter the age of the child. Yes, in the first year for sure. But if the kid's not eating the way they should, they're not going to be cognitively where they need to be. If you don't feed the brain, it's not going to work, right? It's part of it, and also you're going to see the kid is smaller. They're not gaining weight that they should. They tire out. They don't want to eat. So again, iron is never with milk, always with orange juice if they absolutely can. And oh, always please tell this poor parent the stools are going to turn like a starry green black. Can you imagine having a child with normal stools and you give them a dose of iron and then all of a sudden their stool is brown, black, green? The parent's going to be upset. So please let them know that it's going to turn that way. As I said, breastfeeding for 6 months, iron fortified formula helps prevent it at that. So these little critical thinking questions, I'm going to go on so I can get to your cahoots tonight, and that's what I'm hoping for. So sickle cell anemia. Sickle cell anemia is cells that are made in a sickle shape that get stuck inside the blood vessels and blood can't go down. So if blood can't go down to where it needs to go, it sort of backs up in the cells and it expands, causing swelling, redness, pain, heat, and it hurts. And it is always due to their smaller vessels and the blood cell can't get through. So dehydration is a big one. Now, infection also causes dehydration, right? Fever. So you're losing fluid. So always making sure these children are hydrated. Think about a child who is sickle cell going in an airplane. What does that pressure do to the body? It compresses, right? It makes those vessels smaller. So again, having that child drink plenty of fluids before they get on the plane will help. Also, keeping them warm, especially if it's cold. What does cold do? It constricts vessels. We want them to be dilated. And we know that sickle cell, the highest at risk is African American, African children. Those are your big ones that cause it.
So that's the one that the parents has the same gene.
Yes.
Okay.
If both parents have the trait, each child has 1 in 4 chance of being a sickle cell disease. Okay. And that's what it talks about. So you need one on either side that causes this child to get it. So you can't have one parent with it and one without. They both have to have it, at least the trait, not necessarily the disease. They just carry that gene. So sickle cell anemia, when it's, the more severe, we start seeing the cells change shapes at the end of the first year. And again, these little cells that can't get through the tiny little openings in the capillaries get caught. And it's usually fingers and toes we start seeing getting swollen. Those are the big things that we start there, and then it goes on and it clumps and it gets swollen and it's painful and it swells into the tissue, hits the nerves. And these children come in with sickle cell crisis. They're in pain. And it's one of the things we'll really do have to address. Now, sickle cells die quick. So these children are always anemic. Therefore, sickle cell anemia, that's what the name is. It's the shape of the cell, but they die quickly. So again, all the signs and symptoms of anemia this child will have. They'll be pale, they tire easily, they don't have an appetite, they don't want to move. Wherever the clumping of cells has happened, it could be in a finger, an elbow, a toe. What if it was in the brain? You have a headache. Could that be a stroke? Oh, absolutely. So one of the things that was one of the things that happened, I'd be telling the doctor immediately, this child is sickle cells complaining of a severe headache. That we would be doing neuro checks and really watching them closely. Okay. We'll be watching for more things, like vomiting, blood in the urine could be in the kidneys. There's so many things that can happen by an occlusion of a vessel. So just think, is it in the heart attack? In the brain, it could be a stroke. In the kidneys, it cause really bad hematuria. So there's 4 different types of sickle cell. So here's another little transcript looking at it. This is one of the things. Sit down, look at it, read it. I mean, what do we do and how do we take care of a sickle cell child? Well, I'm telling you that this swelling of a joint or an area is because a blood vessel is too small and the cells can't get through. So, what do you think we have to do first to get cells going through? We need to dilate a vessel. We need to give fluids, or we need to put heat on it to dilate it, right? And we might put some oxygen on them. Maybe that will help a little bit. Now, thalassemia is a weird shaped cell. I call this the square shaped cell, but this one doesn't clump or anything. Just, well, it bursts. Very short life, and it bursts. And they are produced, the spleen produces them, and they burst. Now, what would be a problem with red blood cells, all of them bursting? Well, you're not going to have a hemoglobin hematocrit. You're not going to have red blood cells that can do anything, not getting oxygen or iron to the body. But it's putting iron in the body system, which actually you could become toxic on your own iron. So these children will have to live. And we usually talk about, when we talk about thalassemia, it is the Cooley's anemia. It's the major. And it's usually the one that when we talk and test about it, that's the one we talk about it. And these children can live to be adults, but they're going to live on blood transfusions. It could be every week they get one. It all depends on how quickly their cells are bursting. So, because this is one of those anemia that is constantly, it's progressive, we don't see these cells changing again till about the 6 months of life. That's where mommy cells are going. They're gone. And now the child's making their own. So again, it's like sickle cell. It's in the second half of infancy that we're seeing them, looking anemic and they're tired. They're not gaining weight. All of those things we're seeing, and we're finding out why. Well, same thing. This child would be that pale, not eating, fever, just not looking good. But because of all of this bursting of cells, it does cause jaundice and enlarged liver, okay? Because of all these red blood cells just bursting in the blood system. And as I said, these children will live on blood transfusions. Well, a third part of the blood CBC and hematology is we have the blood that gives us iron and oxygen. And they can be many different ways. We've just seen that. Well, there is the infection. We'll go into the white blood cells, but platelets or factors in the blood that aren't present can cause the blood not to clot, and it just is thin blood, and you will bleed unless that blood trait is given. Now, when we think of hemophilia, we usually think of what we call the classic hemophilia A. That's the classic one. Now, the other one is B. It's factor 9, and it's Christmas disease. And hemophilia comes from mom. It's the X-linked gene that causes it. So it's something that if we see one of the children with it, we would do genetic testing and make sure mom is tested. So the thing with giving all of these factors, some children little scratches and stuff will be fine. But, when we get into that real dependent upon the factor eight, now we can sit home. There's a home routine that we give. I've actually seen a father do an amazing job on his son, giving him factor eight. And it was, he had to make powder, mix it with a liquid. He had to start a little butterfly. He put it in a syringe and the tubing. I was really impressed. And he did a great job. But that keeps the kid at home. Also, think about hemophilia and where would a kid bleed? Kids fall down on their knees, right? On their elbows. And then those joints get full of blood and those joint sacks become destroyed, if we don't stop that bleeding in there. So we don't want these kids to become crippled. So giving the factor at home is absolutely the best thing we can do. Sometimes we don't know they have hemophilia for a while, and that does happen. We usually see them come into the emergency room with things like recurrent nosebleeds, epistaxis, or all of a sudden they've got bruising all over and they don't know why. And we can look at one lab value. Yes, of course, we're going to do the blood values on factor eight, factor nine, and some other ones, but a simple PTT. That's like what we test for heparin. Very easily done right there in the hospital lab. And if it's prolonged, we know the possibility of hemophilia is there. Now, at birth, you don't really see this unless they're bleeding. So they're saying that birth, because the factor can't go across, sometimes you will see that umbilical cord, or they do a circumcision at birth. If the bleeding doesn't stop quickly, sometimes that can tell you. If it's a girl, well, we don't got that. So sometimes it's later on to find out. But look at that. Blood clots in 3 to 6 minutes normally. But in hemophilia, can you imagine an hour or longer bleeding? They don't have a big blood volume anyway. So what happens with hemophilia? Well, you're going to be anemic. And actually, you do have leukocytosis as a body response to bleeding, just trying, well, maybe there's something here I need to get, some sort of infection. Sometimes we're going to see platelets try also to help with the bleeding. So we might see those elevated. With hemophilia, sometimes all of a sudden this kid never a problem and now has having hematuria. And I said that if we don't stop this bleeding, what if it was they fell down into their head, hit their head, and now they're bleeding in their brain? This can cause, them to keep bleeding, and they actually can die from that. We don't realize that kids are smaller, and a little bit of blood for us is a lot for them. And they can, get blood into a joint sac or into the brain a lot quicker than the older person. As I said, severe headache, vomiting, disorientation, that could be telling you. Remember, anything, pressure in the brain, what do we look at? Level of consciousness. Are I awake and alert, or am I going not really as alert as I was 2 hours ago? Again, another thing about hemophilia. So platelets. There are times where the platelet count becomes very low. Now, they say normal platelets, I'll say greater than 100,000. Okay, this says 150,000 to 450. Sometimes platelets, I've seen them as low as 10 and 20,000. And what happens is the body's going to try to show you it's happening. And what they show you is the body gets these little purplish rash, and we start getting bruising. I didn't fall down. I was playing a video game. There's no reason for me to have these bruises all over, right? And this sometimes will bring them to the doctor. Now, ITP, idiopathic thrombocytopenia purpura, is when the platelet counts are lowered. It is usually actually due to a viral infection 3, 4 weeks earlier. And it's usually acute, which means that we can take care of it. But the symptoms we're going to see is that purpura, the bruising, the hematomas, where this child, it never goes outside. There's no way this could be bruising like this. And they bring the child in to be tested, and they're going to find the platelet counts really low. And we can treat it by giving some immunoglobulins, but it's those younger kids. So it's 2 to 4 year olds. So the other way I've seen these children come in is actually with nosebleeds, epistaxis. And this is the third one in 2 weeks. They've gone to the doctor. And then finally, we go and do a CBC. We'll do blood counts, those bleeding ones that PT, PTT. Yeah, we'll look at that. But the CBC will show those platelet counts. And then we know what's going on. Now, once we determine that those counts are low during they'll be admitted, especially that's just now been diagnosed, and they're going to do a bone marrow. They want to see the source of where those platelets are being formed. So how do we treat it? Well, sometimes it goes away. Many times, depending on how low the platelet counts in, is they're going to give some steroids, prednisone, but the IVIG and an anti-D. And as we are taking care of them, we need to look bleeding precautions, not sticking them with IM injections, using the IV that you have, looking to see if there's gums are bleeding, nose bleeding, urine, stool, all of those things, bleeding precautions, and a protective environment. Make sure there's no sharp edges everywhere. And again, if you're worried about bleeding or prolonged bleeding, always worry about the brain, that bearing down and causing of stroke. Now, if you're already worried about bleeding, these are some of the medicines that you are going to avoid, okay? Now, do you decrease your activity? Well, you're not going to feel that great when the platelets are lower, but as the levels get high, they can do activity, but you're not going to have them playing football and hitting each other, swimming, going bowling, those sort of things, sure. But, pick and choose what you can. But you can see even caffeine should be avoided with bleeding. Again, it's all about bleeding. It's all about looking at the GI tract, looking for that hemarthrosis, that blood in the joints, and protecting those joints so that they don't get immobile or end up in wheelchairs because we've destroyed these joints. Again, watching their brains, looking for, if they have any sort of stroke going on there. And always, always immunize the child against the viral diseases so they can't get ITP. Top of the list, COVID, influenza, right? RSV. So leukemia, third part of the CBC hematology. So we've worried about your hemoglobin hematocrit, that's my strength, that's my energy. We've got the bleeding, your platelets, your hemophilias, we've looked at those things. Now let's look at the white blood cells. Now, leukemia produces white blood cells, but they're immature. So cancers got into where they make those blood cells, and they've eaten them up in their own little way, and they're not functioning the way that they should. They call them immature white blood cells. So they're not working. Well, if your white cells aren't working, what do white cells do? They fight infection. So if we're not fighting infection, this is what you're going to see, which is going to bring them into the doctor. Low-grade fever. They're going to, now, it also affects your red blood cells also. So you're going to see a decrease in red blood cells as leukemia goes on, because cancer It doesn't just say, oh, white cells, I want you. Oh, red cells, no, no, they actually do both. But it's mostly considered the white blood cells, okay? So they'll be pale, they'll be bruising. It affects the bleeding coagulopathies. So it's a little bit of everything here. And you're going to see leg and joint pain. I had a next door neighbor she was a teenager, mostly leukemia as your younger children, but she was, I think, 12, 13 at the time. And everything on that list, she went to the emergency room with. She just was so exhausted, so tired. It wasn't like her. She had a low grade fever, almost like felt like she had the flu. She was bruising and she was having knee pain. And those lymph nodes were elevated and swollen, and she just didn't feel right. This girl, they did a CBC. Do you know what her initial white blood cell count is? It's usually like 5 or 7, right? Hers was 0.1. And that shows you she came in. Yes, today she's treated, she's cured. She's actually, I found out, she finished her PhD at the University of Miami in psychology. So she's come a long way. It didn't affect her, and I think actually, in a way, maybe there's a bag of think so. Let's examine what I think I want to do. I think part of it's working with kids with cancer also. So, leukemia, gradual or sudden onset, you might see the liver and spleen start getting enlarged because remember, it's affecting blood and blood cells. With that hemoglobin getting low, you're going to see the skin getting that lemon yellow look to it because remember, it's affecting the liver, enlarging it, bile. You'll see those things. Again, it's eating platelets, so petechiae and purpura, you're going to see. And again, anorexia, vomiting, weight loss, and dyspnea, because you don't want to eat. So you don't feel well at all. And that's what you see in leukemia. So you take your history, you do the blood test, and then you're going to do a bone marrow, making sure are the cells all up in there. And that spinal tap is really important. How far is this leukemia gone? Is it already into the brain and the spinal cord? Also, looking at the kidneys and liver, is it affecting that yet? How do we check that? BUN creatinine, right? That's your kidney. Liver, what is that? It's going to be all your liver type, your LDH, and um, looking to see all of the liver functions. Also, remember, as we are going forward, how do we treat leukemia? It's chemotherapy, right? And if we're giving chemotherapy, we want to know where we're starting at, with these children. So, yes, we give certain radiation and chemo that's supposed to affect something in a certain way. It doesn't always mean it does, because we know those cells are going to be treated. It's also going to be, not just white cells going to be attacking, it's going to be red cells and it's going to be platelets, and it's just part of it. So the induction is that first little 4 to 6 weeks. And these children are getting hit with a lot of chemotherapy. And the goal, actually, at that induction is to try to get to remission. But then you're saying there's all these other steps. Yes, it doesn't mean because we've gone in and we eradicated all the cancer that they're all gone. Some of them are stuck somewhere. So we go to the central nervous system, making sure we put some chemo into the spinal column, making sure that that is not attacked. Then, of course, putting them into maintenance, like after a certain while, and usually that's oral medication. And then sometimes it gets up to the bone marrow. So when you think of chemotherapy, what do you think of? You think of hair loss and vomiting, right? Poor little girls are losing their hair, and also they don't feel well, so they're not eating well. So they're vomiting, and they can't eat anything. They do give steroids, but remember, steroids have a lot of things that go with it. It's that Cushing disease, right? Big round face, fluid retention, the body changes. An older child would be upset with that, right? Those adolescents don't want their bodies to feel like that. And then chemotherapy can also cause what we call peripheral neuropathy. And that's just all of your nerve cells get like this irritated numbness to it, is what I call it. You hear that a lot with diabetes, right? Peripheral neuropathy, nerve damage, especially in the legs. And remember, with chemo and with cancer, they're going to be on pain medicine to help them through it. Remember, constipation can be a big thing. You don't want them bearing down and making sure that they're moving their bowels easier. Now, children don't know what's really going on to them. So, nurses, you've got a big role with kids. Sometimes they just want somebody who's safe to sit with and to talk to and be honest about their feelings. And as nurses, I've gotten close to many, many, many patients and many parents also. Um, Children who have leukemia, remember, they're immunosuppressed, they have no immune system. You got to observe them from infection. Sure, we're washing our hands. That's the biggest thing here. Monitoring vital signs, looking for elevated temperatures, telling you there's an infection, right? Looking for bleeding, bruising, nosebleeds, whatever, to make sure that we don't let these children bleed too much because you're losing a lot of the cells that they already are low at. And because the mouth gets swollen and chemotherapy makes them nauseous, make sure you keep that mouth, meticulously clean because it can get swollen and irritated and it's going to decrease their appetite or. So, GI problems. Well, where is the GI system? It's mouth to anus and everywhere in between, anything that hooks up to it, right? So it transports what we need for life from the mouth and goes to the anus. And in between, usually the stomach and the small intestines are there to digest and break down the foods into a product that the body can utilize, as energy and food. We know it's many different organs that do it. And then a lot of it's just absorption of the liquids, etc. Now, what do you see with GI problems? Well, you need your GI system to absorb nutrients for your body to get strong, maintain weight, and to grow. When you see a child that's not growing, not gaining weight, this is what we call failure to thrive. Sometimes that's the first thing that's tell you something that's going on. One thing that I didn't know that I started to look out for pruritus, itching. You're going to have some patients. I've seen it in the children world, pediatrics, and I've seen it in the adults where something's going on with their liver and they itch and itch and itch. And it's something that, oh, they're itching too much. This isn't normal. We need to check the liver function. And that's what we would do. Yes, GI could be pain in the stomach and the abdomen, anywhere. Of course, vomiting, diarrhea, nausea, constipation, bleeding, and then, of course, bleeding up, vomiting, period, but vomiting blood, hematemesis. Now, tracheal esophageal fistula or an esophageal atresia. Well, if there's a fistula, there's an opening between two connections. This is telling you it's the trach and the esophagus. So there is a connection. So when you eat in the esophagus, it goes down, goes across that connection, and it goes into the lungs. So that's dangerous. Now, what is an atresia? Remember, A is always without. So esophageal, which is A, means it's no connection. Atresia, it doesn't go anywhere. It stops, which means the esophagus is not attached to the stomach. Therefore, it can't get to the rest of the body. So both of these here are dangerous. If we fed a child that had a TEF, which had a trach connected to the esophagus, we're gonna make this child eat. The milk's gonna go right into their lungs. Now they're having aspiration. If I fed a child that had the esophageal atresia, it's going to go down the esophagus, but eventually it's going to fill up. And then what's going to happen? They're going to vomit it out. So it could even aspirate there also. So both of those, you're going to not feed those children. Now, imperforated anus, there is no anus. There's no opening from the lower GI tract to the body. One of the first things we do at birth for a newborn infant is to take a rectal temperature. Did you ever wonder why a rectal temperature? Well, I think number one, they're looking for an anus to make sure it's there. Now, happens when that goes on. Well, the anus does a purpose. It gets rid of all the byproducts, what's left over in the stomach. And we're going to have to, this child pretty quickly is going to need to go to the OR and need a colostomy made. They can go back and they can do and make an anus sphincter and open it up, multi-stage surgery. Okay. Now,
So how long
pyloric.
does the new question, Professor? How long does the newborn does have to live like that till the operation
Well, if
is?
you have normal secretions in your body, right? You're just mucus in your mouth. You're swallowing stomach acids. They're there. You are all this mucus there. It's no place to go. So we need to figure it out what it is, and look at the intestinal tract and get them to the operating room pretty quickly
So would
because
they
there's
still feel
nowhere
the
for it
urge
to
to?
go.
Would they
Excuse
still
me?
feel the urge? Will they still feel the urge to use the to have a bowel movements?
Well, they're not going to have a bowel movement until
Right.
we take the bowel out and connect it to the stomach wall lining with a colostomy. That's pretty quick after birth. Now, will they close it? As long as there's enough intestines to work with, there are ways that they can do it to try to make it with least amount of rectal soiling as you can. But it is multi surgeries to get that done. But that colostomy is pretty quick. All right, pyloric stenosis. This is a scary thing that happens. I worked, as you know, in the emergency room the last 10 years of working in a hospital. And pyloric stenosis is one of those things that you've got a infant. They're usually somewhere between um, seven 7 days to 7 weeks, they call it. And the sweet spot, actually up to 3 months almost, but it's that very beginning of life. But it's pretty quick. This newborn infant is all of a sudden you're feeding them. And those pictures up top, the way that formula or milk is coming out, that's exactly what it looks like. You could point them at something and it could land into the garbage can across the room. It is projectile vomiting. Now, why does that happen? So, the stomach is connected to the small intestines. And that valve that holds the stomach to the small intestines is called the pyloric valve. It's a sphincter. And what happens, it gets thickened, hardened, and milk can't get down into the intestines. So again, the stomach fills up, fills up, fills up, and then all of a sudden, daddy's there watching the baby. Oh, what a cute little son I have. And poof, in the mouth, just projectile. So, how do you know that if it's pyloric stenosis versus normal reflux? Well, it's the projectile that makes it. And I also would ask, so when your baby vomits, does he dribble a little bit or is it quite out across the room? And if they tell me it's across the room, I would take my hand and go underneath their abdomen by their xiphoid process, and you will feel a little olive. I actually call it a little marble because it's a little hardened. It's that hypertrophic pyloric valve in the stomach. So next thing I tell them, don't eat anymore. And
Where
they
would you
will
put
go to
your hand again?
underneath the abdomen, right underneath the xiphoid process, where the stomach is, a little bit to the right or left. So the top of the abdomen, right under in the midline, you're gonna feel, they call it a grape. I've heard it called an olive. I heard it called a marble. It is quite thickened and it's really hard. So these children, you're going to make them stop eating because they're just going to keep vomiting. They eat, they feel good, they vomit, and they want to eat again. You feed them again, they vomit again. And until we get this open, that valve that connects the stomach to the small intestines, they're going to continue. They do surgery from the ER, they go to surgery, they go to the floor. They do it quick. They're usually home and within a day or two, and usually there's no untoward effects. All they do is dilate that valve and open it up to let the fluid go through, the milk go through. Now, celiac disease is the body's inability to absorb gluten. Now, what is gluten? Wheat, rye, barley, and oats. Any of those flours, you cannot feed these children. We don't start seeing a child who has this until we start feeding them. And we start feeding them when? At 6 months. But usually the flour stuff is usually after the age of 1. That's what they say, up to age 2. And they hurt when they're given celiac disease. They do not absorb fat really well. It's part of them too. And they get this big protruding abdomen because of that, because of bad absorption. These children also have very foul smelling stools that you will see. And what they call is, they have no buttocks or the atrophy of their buttocks. There are different sorts of celiac disease. The classic, it's where the little tiny little hairs of the small intestines don't like these things, and the barley, the wheat, the rye, the oats, and they're not absorbing it. And then it just flows off, diarrhea, and it causes their tummies to hurt. The atypical, you're not going to see as much of the pain and the symptoms, but you're going to see them with anemia. They're not eating the way they should, they're not absorbing the way they should. And then the silent just happens. They find it arbitrarily. They didn't know why. Now, there's something called a latent, but it is sometimes just a wheat allergy and it causes a rash on them. Now, Hirschsprung's disease is the descending colon, and it gets big and dilated, and there's no nerves in the area. So as it gets bigger and stuff doesn't go down, it stretches, you don't feel it because there's no nerves there. What would alert you to Hirschsprung's is these children do not have a stool in the first 2 days of life. And most infants, they come out having a bowel movement, that sticky meconium pretty quick, don't they? Well, they don't. So they call it an aganglionic megacolon. Aganglionic is no nerves. Megacolon, it's holding that impaction there, and stool can't flow, so it is an impaction of megacolon. Okay, what would you see? No stool first 2 days. You might see a distended abdomen, but you're going to see if any of the stool comes through. It's the end portion of the intestines is very skinny. And this big area where it has all this fill up of all the intestinal waste, you might see like a frosting baster where little ribbon comes out, and you might see that. That would be your other clue. The other bay would be is again doing an X-ray and finding it there. They say it's more in boys and more common in Down's children. So this is a picture of it, what you would see. As I said, you're going to see ribbon-like stools. You're going to see that intestines, abdomen getting big and large. And what do we do for this one? Well, in this one, we're going to first say something's going on. We're seeing something happening, no stools. Let's do a biopsy, an enema, or something to find out what does that look like. Once we determine the biopsy showing us no nerves in the cells, they're going to say, okay, it's useless tissue that doesn't function. It needs to be removed. They will do two types. Either they'll take all that piece out and pull up some to leave it for a temporary colostomy, or sometimes they do a pull through procedure where they can connect it up right away. Either or, depending on severity of the child. Okay, this is a child because of going through this at birth. You need to watch their stools as they grow up. Constipation, diarrhea, stools a day, nutrition. Weight is going to tell you a lot about nutrition. Am I eating enough? Well, look at my weight. Is it maintaining, or I'm not where I should be? Now, intussusception. This happens on younger toddler preschooler ages, a young preschooler, and the intestines pull up into each other. And it's a sudden onset of intense abdominal pain. What you'll see is number one, it's going to hurt, and they're going to tell you, they're going to scream. And in their diaper or in their underwear, you might see this, what we call currant jelly mucus, a little bit of blood in it. And that's telling you it's being pushed out. Now, usually these come out, go in by themselves, and just put more roughage, fiber in the diet to keep it more out. But it all depends. Sometimes we have to do an enema to push it out, and sometimes we have to do surgery and we have to remove it. What you see in the belly on the intussusception is what we call a sausage-shaped mass. It's that intussusception, those intestines within each other, okay? And as I said, we can take and push it out by giving an enema. It sort of forces it to straighten out. We would prefer that, but if not, surgery will have to be done. All sorts of hernias. Now, I love the little belly button ones. You push them in and out, they're soft, and it doesn't hurt the child. Those are benign. Parents usually fix them as they get older because they want their little girl, the little boy, to have a pretty belly button, basically, right? But if it's now hurting, that's going to be your problem. That needs surgery. Gastroenteritis, probably one of the most common GI complaints of kids, vomiting and diarrhea. And what is that? How do we treat it? Well, if we're having diarrhea, it could be due to the food. It could be that parents are feeding them too much. or they left the formula out, it wasn't refrigerated, didn't wash your hands. All of those things could cause it. And there actually is sorbitol in some of the formulas, in even some of the things that we do, like with charcoal. So sometimes that can do it. The thing with diarrhea, vomiting, is all about electrolyte imbalances. So what do we lose? And this is important because it's a ABG type question. So if you're vomiting acid. So what are you left with, and what would be your acid-base status? I'm losing acid. I'm left with metabolic alkalosis. Now, if I'm having diarrhea, because of all of the digestive enzymes, this alkaline is being lost. So I will be left with metabolic acidosis. Those are the two big ones that I've heard questions about.
So it will be the opposite. Whatever you're losing will be
Yes,
the opposite. That's
yes,
basically it.
yes. And
Okay.
it's because, and why is it opposite? The body's trying to compensate for what you lost. And they go the other way to try to balance the scale. Did that make sense to you? Okay, good. Because it's one of the things that had me pondering for years as a nurse. How do I remember these things? Now, vomiting, remember, this is all of your acid coming out. You're left with metabolic alkalosis, and if we don't treat it, it's going to cause your body to say, I don't think so. And you can code and die from either your electrolytes being out of whack or even your pH being in an improper cycle there. Vomiting could be caused by many things. It could be just food. It could be due to a viral something. But also remember, vomiting is also a clue to intracranial pressure. You have a child who fell down and hit their head, and they're complaining more and more of a headache. Be aware it could be something's happening in the brain. And also, every time they vomit, there's a chance of aspirating that into their lungs. So it's something that we really want to prevent. Gastroesophageal reflux. We hear this with babies all the time, right? They're always spitting up. I can't keep it down, always spitting up. I mean, we'll see it, yes, in the neuromuscular delayed, cognitively delayed children, has to do with the way that their muscles and their, nerves work, and they don't do it properly. But there are many children that once they get the food down, it keeps coming up. Again, we want to do something to help them keep the food down because they worked that hard to get the food. Now they're not getting the nutrients, and we want them to get that. So we want to keep it down, and it could be just burping, could be medications. It could be just as simple of adding just a little bit of rice cereal in formula or breast milk that can hold it down. Sometimes that's all it needs. Now, in diarrhea, the thing with diarrhea is you have diarrhea and you just want to stop feeding them. Well, and you just want to give them Pedialyte or um, Powerade or Gatorade, right? But all you're doing is giving them liquid. How are you going to stop diarrhea if you're only giving liquid? So, what do we do for these? Well, number one, yes, you'll rest them initially, but we need to look out. What do we do? Now, it could be caused by a virus, bacteria, a parasite, could be all of those things. First thing is to put them on a blander diet. And I actually found in my career, they just give a lactobacillus. And that restores the normal flora in the intestines. And as soon as that stool becomes thicker, that's when they say to stop giving it and just return them to their diet. Okay. Now, if it continues and nothing's helping, something's going on. Is it a malabsorption? Is it a food allergy? Many times, diarrhea starts when you start feeding them food because they're allergic to some sort of food. Constipation, stools are just too thick, hard, can't get them out. We know that older kids, this is something going on in their brain. Something's happening and they're unhappy. Could be that they lost their dog or you had to move or your best friend, doesn't live next door anymore. Those things can cause constipation. No, we never with children give daily laxatives or enemas. The first thing we're going to do is to give them more fluid in their diet. That's always number one. And then putting more roughage in their diet is also going to help also. Sometimes with constipation, it's what we call encoparesis, where they're having constipation, but they're having liquid coming around the outside. It's so hard, and there's liquid just trying to get out. That's called encoparesis. Children under age 2 and children in general, one of the biggest things and risks for death and bad outcomes is dehydration. So we really need to make sure that we replace fluid that's coming out. That's why we tell you sips of fluids, of their favorite fluids, if they have a fever, right? To replace any of the extra fluid that they're burning with these fevers. Absolutely. So one of the things with children is to make sure that um, we're looking at their weights, we're looking at their heart rate, we're looking at blood pressure, how much fluid is gone. Let's go back and let's start revisiting it slowly, giving them more and more fluid. We know that there are several types of dehydration. Um, Isotonic is just normal body fluids, it's happened. Or hypotonic, all of a sudden you have more water than you do of, your electrolytes. And hypertonic is the opposite. So depending on what we have, how much fluid, how many boluses, that will happen. Now, overhydration can happen. There are some conditions that it happens with, but in overhydration, the big thing that we worry about is actually the brain getting too much fluid. If you have a already a condition about the brain, having fluid on it, giving it more fluid, as in overhydrating, can be dangerous. Um, when we see overhydration, we can see it by there's edema everywhere. It could be in the eyes, all dependent edema in the legs. And that word anasarca is when they're everywhere, when they're swollen. And how do we measure if we're getting any better with over or under hydration? Intake, output, daily weights. Those are your big threes. So nutritional, as I said, if they're not eating, they're spitting up, not getting what they need, you're going to see a child whose weight is not where it is. I said that children, not adults, every time they go to a doctor, ER, urgent care, they do a height and a weight. They're making sure they're gaining the way that they should. So if we're seeing a failure to gain weight, something's going on. We'll be looking at a physical problem, that congenital heart. Is the heart's beating real fast, burning off calories? Or is it something like cystic fibrosis, malabsorption syndrome, right? Or is it something non-organic? And it could be something where environmental, it could be neglect. This is one of the big things. Look at Maslow's hierarchy of needs. I mean, food, clothing, and shelter are the big things, right? And there is neglect where, and I've actually seen it, where they withheld food from this 7-year-old boy. And that picture of those legs looked like the 7-year-old boy when they finally got him to the ER. And he made it, by the way. So failure to thrive, we got to find out why. Is it a problem? We know that there's mother-child relationship issues that, need help and it's like understood. I mean, I had a niece who had an issue. where at first she didn't know how to work with her son. And of course, she had a great family, a great husband. I mean, the child has everything he needs. She's grown out of it, but it was that depression right after birth. And it does happen. So these things need to be looked at. And also, looking at when they came in prenatally, what was going on there? Were there any clues or hints about all this bonding? So your appendix. How many of you still have your appendix in? Not many. I mean, I think a lot of you had them taken out, usually when you were a child, somewhere school age, even adolescent, you'll see it. It is that McBurney point, right lower quadrant, rebound tenderness. And it's that little piece of tissue that is at the cecum, the connection of the small and the large intestines. And it just says, I'm angry and I don't want to be here. And it creates pain. Our concern is getting it out before it ruptures, because that's the inside of this piece of tissue and it is septic. So it will cause peritonitis. Thrush, that white stuff on the tongue of an infant, right? You try to scrape it off and it won't come off. It hurts, so they're not going to eat. That's why they're. And what they'll do is they'll take a mycostatin, put it on a little tissue, rub it around, and they will get it coming off. And it takes a couple of days. Also, remembering if you're on bottles or on breasts, make sure they're washed before we use them. Enterobiasis, pinworms, big things in young kids. These kids like to go outside, play in dirt is a big one, actually. What they say is the keep your fingernails cut so there's no place for these eggs to get in there. Is what do kids do in the mouth, right? Go outside, play. It's dirt underneath their fingers, and they'll eat them anyway. All of a sudden at night, they're complaining of intense itching and keeping them awake. At night, you'll go with a piece of scotch tape, put it on their anus, pull it up, and they're itsy bitsy tiny things. But that's how we would diagnose them, and there's medication. Roundworms is bigger ones. Again, we also are these usually we think of roundworms. We think more of our animals, right? But same sort of things that we would see. We don't have good sanitation, good hand washing. We have there's human waste is around, and you can't be clean. And many people, does everybody have a house that they can live in, or they have to live in certain places? I mean, I know living in Miami and you have all of these migrant workers, and could they have it because of where they have to live in order to make money? One of the things is they're having this cough, and that cough is because the worms are coming up and they're tickling the throat. So it does happen. Again, there are medications for it. Poison control, first thing, get the poison out of their mouth, as in take it away, call poison control number, and whatever they say, you do. We take a quick history, vital signs as a nurse in the triage in the ER, call poison control and find out the treatment. Lead poisoning is still a thing because there's still some lead paint out there. And that's where they like to chew on those windowsills. It's one of the big places that we still see it in older buildings. And yes, lead can have a big problem and can affect the brain, causing mental retardation. Children explore the world in their mouths, right? So everything goes in their mouth. Now, I'd like to tell you it was a little dime they like to swallow. It's always a quarter. Every time is a quarter, although this I think is a nickel. Remember, when they come into the ER or for treatment, first thing, get them calm. Calm them down. They're breathing, right? And then they actually put a Foley catheter below the coin, make the balloon big, and they sit on the surgeon's lap. They pull the Foley catheter and it comes up. They used to go to surgery and do a bronchoscopy. They don't need to anymore. Any questions? A lot of stuff. All right, let's do a cahoots. I made it to it. So let's do it. Week 7. I'm still amazed how quickly this is going. Who wants to win today?
Professor, I'm still here. For some reason, um my computer fell. My camera just went off, but I'm getting on
Okay,
the
all
code.
right.
Hey,
Thanks
stop it.
for letting me know. Our children are acting up. Children behave. Who else is coming on? We haven't done it in a while. Come on, let's have a fight here. Has everybody been doing the cahoots when I send them to you? Because they are very, very helpful for your quizzes, for your exams, and your HESI. Which finding in a newborn is suggested of tracheal esophageal fistula? That's the connection that goes between the trach and your esophagus. What would you see? I mean, a newborn still has mucus. They're still wet mouths. They're still swallowing. So you're going to see them choking, gagging, because what they're doing is they're aspirating their own mucus. The child's been vomiting for the past 2 days. What acid base imbalance would the nurse expect? What does vomiting do? What's in the stomach? In the stomach is acid. Oh, I vomited out. What am I left with? That's the way you need to think of this.
Can you put the number again on the chat for the cahoots? I was only able to get the first three.
8762113. Hereditary blood disorder that the body does not produce enough adult hemoglobin. And this is hereditary. And it's not sickle cell. And this actually comes from the Mediterranean Sea. And they produce these rectangular shaped cells that just, they're not what the need, and they burst quickly, so the body's not getting iron and oxygen. That is the classic definition of thalassemia. Why are rapid respirations a possible cause of dehydration? Think about it. What happens? So, what happens is when your mouth is open, you're breathing fast, you're in distress, you're just absolutely evaporating up all the liquid in your mouth. And that can be a cause of dehydration. Probably you're with a fever and many other stuff, but it is a cause that can happen. What would the nurse expect the parents to report of an infant with pyloric stenosis? Remember, this is a pyloric valve is thickened and hardened, and milk can't go down. Oh, they can drink all they want. They want to eat. They're hungry, hungry. Problem is, food can't go down, so it's projectile across the room vomiting. a multi. How would you treat chronic constipation in children? So raw vegetables have more fiber than cooked ones. So raw vegetables and always fluid intake. Remember, iron causes constipation. So that's why not that. And I've already said the cooked. A child has been scratching the anal area and complaining of itching. What does the nurse suspect? This is what we call pinworms. Okay, pinworms, those tiny little ones. We take the scotch tape, and if one person in the house has pinworms, they say to treat everybody, the whole family. What instruction will the nurse give to the parents about preventing the spread of reinfection of pinworms? So, how do you prevent the spread? Number one is just keeping those nails short. Okay, that is the big thing. Keeping the bathroom bleach solution, that doesn't prevent it because it's out there in the dirt. And then the rest, no, it's all about nails short. And I would have them wash their hands when they come in. Which food would the nurse recommend to include in the child's diet who is constipated frequently? So cooked vegetables, no, I want raw ones. Whole grain cereal is actually the best. It's fiber, right? And that's going to help it move a lot better. What condition is characterized by pain in the right lower quadrant at McBurney's point? So that is your appendix. Quashquar is a protein deficiency, has nothing to do, that's the overall generalized. It is not pain. Might see an distended abdomen. What description of a child's stool characteristic leads the nurse to suspect intussusception? Ray said this is when you'll see sudden onset of pain, and those bowels go telescope into each other. And I told you to check the diaper or their underwear, and you might see it's called currant jelly, a little bit of blood. That's what you would see. Greasy, foul smelling is more your cystic fibrosis, okay? Or your celiac disease. Those, because they're losing fat, they're not digesting. This is the cystic and your gluten free, right? What does the nurse expect the appearance of a stool of a child with celiac disease to be? Well, here we go. Because remember, they're not digesting all their food that they need, right? And the big thing is fat. That's why they're even losing fat vitamins. They need replacement also. And it is bulky, it is frothy, and it's almost like a foamy thing, and it can be foul smelling. So maybe I should take that one and put it over there. But remember, the stool will look different because of what the body's not absorbing. A 7-month-old infant's admitted with a diagnosis of acute gastroenteritis. What will be the nurse's priority goal? What do you worry about with acute gastroenteritis? Remember, that's vomiting, diarrhea. Gastro, stomach, enteritis is your bowel. So something stomach bowels going on here. What's your biggest concern? That's all about fluids and electrolyte imbalances. Measuring, looking at the child, looking at their heart rate, blood pressure, urine output, capillary refill, looking at their daily weights, intake output. These are things that will tell you your fluid balance in these children. After surgery for pyloric stenosis, an infant is hungry and crying. What is the most appropriate nursing action? So they've stretched out that valve from the stomach going into the small intestines now. So we've opened up what was creating that projectile vomiting. And they say at first, let's go easy with what they can have. So an ounce of glucose water and just see how are they tolerating it that. And then they'll go and they'll progress up and they'll get them on their regular diet, usually within a day or two, and they'll go home. A multi. A child's brought into the ED with a suspected appendicitis. What are signs and symptoms? What would you see? So we're going to have that rebound tenderness. We're going to have when you lift the thigh, you're going to like lift up, it's going to be hurting. And we know it's right lower quadrant pain. Is there going to be guarding? It's more of you don't want to be touched, you're going to protect, but it's not necessarily guarding, it's more of the rebound tenderness. Which statement by a mother may indicate a cause for her 9-month-old's iron deficiency anemia? Why are they having it 9 months? Well, what it like thinking any anemia, iron deficiency, it's nutritional. 9 months. What's going on with a kid nutritionally then? It's all about they're not getting their formula, right? They're not getting the iron that they need, or they've switched them over to that regular milk. And it does happen. And that's we do see that iron deficient anemia, especially the older infants, and of course the toddlers, that picky eating we start to see. What's the most common nutritional deficiency in children? Iron deficient anemia, yes. Hereditary blood disorder that the red blood cells are in a crescent shape, and they also die quickly. And that's sickle cell anemia, yes. Regulates how many RBCs are produced. So erythropoietin, we've heard about that in renal. You've probably heard that in your MedSearch 1. Remember, erythropoietin is needed in order to produce red blood cells. And either we'll have the body make it itself, or we can also give a synthetic one that also works. Use that a lot in the cancers like leukemias. What information should a nurse include in a teaching plan about home care for a child with hemophilia A? Well, what do we know about hemophilia? It's all about bleeding, right? Bleeding that doesn't stop. So teaching is all about what happens if my child is bleeding. Well, it's really similar. This also similar to maybe a sprain, and you're going to do that rice. You're going to elevate, rest, ice, contain it, elevate it, and keeping that pressure there. And giving that home dose is what we'll do also. We're not going to give aspirin to hemophilia. They're going to bleed a lot more. And never a firm toothbrush, so he's a soft one. What will the nurse teach the parents of a child with a low platelet count to avoid? Aspirin. And actually, the other one they were saying was caffeine, wasn't it? I was about that one. It was on the PowerPoint. A child with leukemia has widespread purpura and a platelet count of 19,000. What is the nursing priority? So again, you've got a chance for bleeding. We know that these children, if the child bear down too hard, they could burst a vessel in their brain. So you are assessing the neurological status would be your priority at this right now. Which statement indicates an understanding of health maintenance of a child with sickle cell disease? I mean, this again is an autoimmune or immunosuppressive disease, and we have to do the really good health maintenance. We have to do all of that preventative care for these children. The best we can do will help them. So, what do we know about sickle cell? What's the one thing? Well, keep the blood vessels large. Make sure they have plenty to drink. Up in a plane, make sure there's plenty to drink, right? Thinking about if it's cold outside, keeping them warm. So again, keeping the vessels big. That's a huge concept in sickle cell. Keeping those vessels as big as we can. Most common cause of anemia in children. And it's iron deficient anemia, most common of all of them. What is a complication of repeated blood transfusions for a child with thalassemia major? Remember, this is the square shaped cells. They don't produce enough adult hemoglobin and they burst quick, and iron and oxygen go into the body, and there's no hemoglobin left. So these children need repeated blood transfusions. Remember, with complication, the hemospherosis is a big thing. Remember, also, there is getting antigens and antibodies in blood that make it difficult to find blood. And that's usually what causes the death, is that inability to find proper.
I have a
Sure.
question, Professor. What is that difference in medical terminology now that we have those four options from hemo and hema?
Hema is blood, like blood into the joint. Hemo is the blood causes this to the blood. Like hemoptysis is throwing up blood. Hemarthrosis has to do with blood collecting around a joint. They're very, very similar. It's all blood, hematuria, blood in the urine. Okay? Okay. Hereditary condition where the blood does not clot normally. And that's called hemophilia. Now, ITP is when the platelet count, it's not hereditary, it's an acute condition following a viral illness, and it's the platelets drop all of a sudden, so it's not hereditary. But hemophilia is factor 8, factor 9, and there's also a couple other ones. A recent blood count for a child who received chemotherapy shows neutropenia. It's the priority nursing diagnosis. What does neutropenia mean? And neutropenia means low neutrophils, which are white blood cells. So low white cells, you're at risk for infection. So that is the answer. What type of cells carry oxygen and carbon dioxide in the body? And that's your erythrocytes. Very good. Leukocytes is white blood cells. That's neutrophils. They carry all of the infection fighting stuff. What can occur? Iron deficiency anemia goes untreated. So what can happen if you let the iron in the body, we don't do anything? That means the iron is low, your hemoglobin hematocrit are low, there's no red blood cells. What happens? The heart beats, trying to get oxygen around, and nothing happens. And you go into heart failure. Period. Heart failure is the biggest thing here because the heart's trying to get oxygen to the body, but there's no cells. So there's nothing to carry it. So the heart does eventually fail. A multi. What skin assessments would alert the nurse to bleeding for a child with a low platelet count? So you would see bleeding looking stuff. So anything with blood, petechiae, purpura, ecchymosis, and adenopathy is lymph nodes, that's white cells. So it's the other ones. What is the name of the malabsorption problem that results in gluten intolerance? No wheat, rye, barley, oats. Rice is a great alternative. That's what I used to recommend to the kids. You find a lot of rice stuff out there. And it's celiac disease. And last question, hereditary blood condition where the RBCs are crescent shaped. And yes, that is sickle cell anemia. Good job, guys. We made it through the night. Good. Claudia, good job. Number 2, Courtney, good job, Courtney. Trish, good job, Trish. Number 4, Dee and Andrea, good job, guys. And there's a lot of tricky ones in there, so that was a good job. I'll be sending all of these out to you so that you have them. If I can be of help to anyone. Now, you all got your exams back. Anybody who wants to go over it with me, let me know. I am always here, willing to do that for anybody who needs help with math. Your math, just let me know, okay? So next week, week 8, we're going to be starting our reviews again, and week 9 is going to be our exam. So I'll be sending out that list of your study guide and the other professors and when they're going to do it. It's listed on the calendar, but I put it as an announcement for you, so to make sure that you have it. So
Thank you
have a
so
gr-
much.
have a great weekend, guys.
Thank you so
Bye.
much, Professor.
Always welcome. Take care.